Good afternoon. I'm going to be talking to you today about Parkinson's disease, and I will be referencing Michael J. Fox some in this discussion because he's a pretty popular actor, and I think many of you know who he is. The first thing I would like for you to do is use this link that's provided to watch this video called Michael J. Fox Then and Now. He's very candid about his disease, and I think it will help you to get a good perspective on how it impacts his life. He was diagnosed at the age of 29, and he's now well into his 50s. And he's choosing to consider it a circumstance of his life and not the definition of his life, which is a pretty powerful attitude. Parkinson's disease, unfortunately, is a chronic progressive disease. It is not something that will improve, and there really is no treatment for it. It is a disease of the basal ganglia in the brain, and this is the area that controls voluntary movement. So when people begin to present symptoms, they'll have slowing down of initiating movement or executing it. For example, I want to stand up, I want to walk across the room. I don't have any problem doing that. But someone with Parkinson's could have trouble initiating those movements. There is an increase in the muscle tone. And one of the biggest signs that is usually an early thing that's caught is tremor at rest. Now, all people who have tremors do not have Parkinson's, but it is one of the characteristics. And then they can have disturbance in their gait. So they're moving, trying to walk, and it's just not a smooth, fluid movement like you or I would do walking across the room. This slide basically shows you the three classic symptoms of Parkinson's disease, which is tremor, rigidity, and bradykinesia. And bradykinesia is loss of autonomic movements, things we don't even think about. So we don't think about swallowing or blinking our eyes, but when you have Parkinson's disease, those things can be impaired as well. So diagnosis, of course, increases with age, as in any disease, because the longer people live, the more chance they have of being diagnosed with a disease. It is more common in men, though women as well can be diagnosed with Parkinson's disease. They really don't know the exact cause of this disease. They think it could be environmental exposure, toxins, family genetic makeup, but they really don't have a true understanding. There is a part of Parkinson's that's called drug-induced Parkinsonism, and that would be coming from taking like large doses of antipsychotic drugs and drugs for those kind of diseases, and it can actually lead to symptoms such as Parkinson's. The biggest thing you need to understand that it's a lack of dopamine in the brain. So you and I have dopamine, and this is how our brain communicates with our body. So I know I want to pick up my glass of water and have a drink. My brain just says, hey, reach over, pick up that glass of water and take a drink. And then I swallow, and I have no trouble maintaining my secretions. I don't aspirate water. When someone has Parkinson's, they may not be able to initiate those movements in the manner that we can. It won't be as fluid. It can be interrupted. So anytime the neurotransmitter dopamine is impacted, it results in symptomatic behavior. So this is just showing you the area of the brain, the nigrostriatal area. And this is an area where we have many, many nerve fibers that extend from this area, and they help to cause our body to function in a certain way. It can impact cognition, motor function, decision making. We really don't think about those things. They just naturally function appropriately. When someone has an interruption in these pathways due to the lack of the neurotransmitter, so we have a communication problem, then we end up having interruption in movements that should normally be fluid or even autonomic movements. Now this is just showing a little, I guess you'd say, I can't even think of what the word is, a little picture of how the communication takes place and how if there's an interruption in the communication, then we don't have those fluid movements. And you can see where that would lead to complications for the patient. So here's an image of a PET scan. And you can see in a normal PET scan, there's all of this white light areas in here showing a lot of activity. And in the patient with Parkinson's, it's much darker. There's a lot less communication and activity. So that decreased activity or communication leads to decreased functioning of the brain cells. So this is just a visual that shows you how that patient has been impacted. The thing with Parkinson's, it's a gradual onset, and it is insidious, meaning it's causing harm, but it's not easily noticed in the beginning. You could kind of liken it to hypertension. It can cause a lot of harm if we don't catch it, but in the beginning, we really don't know it's there. So it's progressing. It is a chronic, again, progressive disease with no known cure. So it's very important to diagnose someone as young as possible and hopefully get them on medications to help at least treat the symptoms of Parkinson's. Again, I want you to keep in mind what are these classic symptoms, because you need to recognize that in your patient scenarios. So your tremors, the patient can be very rigid, which means they have resistance to passive motion. So you and I, maybe we want to throw a baseball or a softball and we can do an underhanded throw. We just rotate our arm. It might not be that fluid for someone with Parkinson. And then bradykinesia. So those are those autonomic movements that we don't think about. We don't think about blinking our eyes, swallowing, managing our secretions, self-expression. And those things can be impacted in the patient with Parkinson's. The beginning stages, one of the things that is usually noticed first is tremor. It can be a mild tremor. It can be complaints about writing or that writing is kind of trailing off. They can start to have a limp, or their arm may not swing as much as yours and ours would when we're out walking. As the disease progresses, then we can have this shuffling. So they might shuffle their feet along the floor where you and I take steps and we just move along on our path. And loss of postural reflexes. So when you think about it, you and I sit in a chair or we stand up, our posture supports us. We don't have to think about it and say, okay, posture, I need you to keep me from bending or stooping over. But with the Parkinson's patient, they may lose some of that. So you may see this defined posture where they're kind of bent forward. And it can even have an impact on speech for these patients. So when we talk about tremor, I want you to again keep in mind that everyone who has a tremor does not have Parkinson's. There is something called benign essential tremors. Many people get this as they age. Just because someone has a tremor, it does not mean they have Parkinson's disease. But as time goes on and the tremor increases, they may notice it more when they're resting, when stressed. They could have more tremor when they're concentrating more. You will also see something that's called pill rolling. And this is a very classic manifestation in a Parkinson's patient. And they kind of just move their thumb and forefinger in this rotary motion, and they're not even thinking about it. It's just happening. So that is called pill rolling. And that is something that you could see in a Parkinson's patient. One thing you won't typically see is shaking of the head. That's not usually impacted by Parkinson's. So it would be more of hand tremors and the pill rolling and then the loss of fluid movements. Now, as I said, benign essential tremors can be misdiagnosed. I think the statistics are that out of maybe 8 people that have tremors, only 1 might be diagnosed with Parkinson's. So this is something that can happen to older people, and again, 8 times more common than the Parkinson's. Rigidity, so that's the resistance to passive motion when we're doing range of motion activities. So again, I may want to play softball or toss a softball to my little granddaughter, and I just rotate my arm and toss it. But for someone with Parkinson's, it might be called or identified as something called a cogwheel movement, kind of like on a even a clock where it's not real fluid, it might kind of be jerky. And that's something that would manifest in the Parkinson's patient. This is caused by sustained muscle contraction. So when you think about it, if a patient has sustained muscle contraction going on, they're going to have a lot of complaints. They're going to have a complaint of fatigue. They're going to be sore. They're going to be tired. And it can be throughout their spine, their body, their legs, because anytime you tighten up your muscles and use them in a sustained contraction, it exhausts them. So that's a common manifestation for our Parkinson's patients. Bradykinesia. So this is the slowing down of initiation of movements that you and I wouldn't even think about doing. So maybe someone starts to blink very slowly, or they swing their arms real slow when they're walking. The biggest concern with this kind of manifestation would be things like swallowing, maintaining airway, because you and I don't think about our secretions, right? We're making saliva all day long, all night long, and our body just manages it and swallows it. But if that is interrupted, they could be at a very high risk for aspiration. So definitely that is something to be concerned about with our patients. Also, changes in facial movements. It is described by many as a mask appearance when Parkinson's has progressed, because they don't have that ability to express in the way you and I do, raising eyebrows, smiling, and so forth. So here's a great visual that can show you the appearance of a Parkinson's patient as their disease has progressed. So they might have that mask-like appearance, loss of posture maintenance, so they're tilting forward. Their speech could be slow and monotonous, even slurred. They could have tremors and then shuffling across the floor because they don't have that fluidity of movement to just walk across a room. You also want to be aware of these non-motor symptoms that this patient can have. Obviously, depression and anxiety are huge in the Parkinson's patient because it's a life-altering diagnosis. These patients know they have a chronic progressive disease that is not going to improve. So you can only imagine how that could impact them in the area of depression or anxiety over what's going to happen. Will they be able to take care of themselves, and the complications that come with the disease. We've talked about fatigue, pain, aches because of that sustained muscle contraction. And then they have a lot of problems with sleeping and also constipation. So you got to ask yourself, why would someone with Parkinson's have constipation? Well, when you have slowing of things, that could lead to constipation. They're probably not moving as much. And maybe they're not even drinking as much because they're having trouble with swallowing. So we definitely have to keep that in mind. Also, as things progress and it starts to impact cognition, they can have short-term memory loss. Non-motor symptoms that can really be devastating for the patient could be impotence and short-term memory impairment. When someone starts to lose their memory, that's a very frightening thing. They start to worry about Alzheimer's and dementia, and we need to keep all this in mind. And then a lot of trouble with sleep. Trouble staying asleep, they have nightmares, they're tired during the day. So make sure you understand the overall presentations that your patient could be complaining about with Parkinson's disease. As the disease progresses, we know it's going to get worse. Again, it's chronic and progressive with no known cure. So you're going to see more of these motor symptoms, more neurologic problems, probably more forgetfulness, anxiety, depression. And 70% of these patients can actually end up with dementia, which is very concerning for the Parkinson's patient. Complications can include dysphagia, and because of that, the patient again has a risk of aspiration and even malnutrition. When you're having trouble eating, swallowing, even chewing, it's very concerning for the patient. So they may not eat as much as they need to or get appropriate nutrition. They can also have debilitation from immobility that could lead to pneumonia or urinary tract infections, and even skin breakdown from sitting or laying in the same position for a length of time. Another concern is orthostatic hypotension. So that makes our patient even a higher risk for fall and injury. So these patients have risk for airway and aspiration problems and a huge risk for fall and injury. So we've got to keep that in mind as their disease is progressing. There are no specific diagnostic tests for Parkinson's disease. The only way that they really diagnose it is based on the patient history and clinical features, and then they start to administer the meds for Parkinson's. If that lessens the symptoms, that is considered their diagnosis. So if your patient has come in and they have this history with two of the three classic symptoms, and then we give them Parkinson's medications and the symptoms improve, that would be considered the diagnosis. So we're going to talk about this gentleman. He's a 67-year-old, and he comes into the clinic with a tremor in his hands, which is interfering with his writing. He says he has muscle aches and he's drooling saliva and he can't swallow. He doesn't remember when it began, but it was a while ago. So this is some pretty big clues. I mean, he's got that fatigue that could be from the sustained muscle contraction. He's got the inability to maintain his secretions, so he's drooling and not swallowing well. And he really doesn't know how long it's been going on. He's got the tremor, so he definitely has some of the classic symptoms going on there. We do a physical exam and we see that he's very rigid. And as we observe our patient walking across the room, he's shuffling his feet. We also note that he has a blank expression. He's not smiling in response to conversation. And he's doing this pill rolling with his hands. So this is a classic thing again. And we would be looking at this patient thinking he absolutely could be diagnosed with Parkinson's. So this says he was diagnosed. Truly, he would be based on the presentation. However, we would give him the medications and be expecting that the symptoms, some of them would improve because of the medications. He is very anxious and worries about his tremors and that they won't stop. So you have to ask, what kind of things could I tell the patient? Well, I always recommend you've got to be honest and upfront. If we're concerned about this being Parkinson's, we need to tell the patient that and let them know that, yes, it is a chronic progressive disease. However, there are many medications that can help with the symptoms. There are also a great deal of studies and trials going on to help try to find a cure for Parkinson's, and that we're going to just do everything we can to relieve the symptoms for our patient. So we're going to start talking about drugs and educating our patient on what they need to manage their disease. What we're trying to do is get that communication back, get more dopamine in the brain so those neurotransmitters are communicating and saying from the brain, I want to do this, to the actual action of doing it. And these drugs can either enhance dopamine that's there, or they can release more dopamine, or they can block the effects of overactive cholinergic neurons in the brain. The first line drug in almost every case is going to be a drug called Sinemet. And Sinemet is a combination of levodopa with carbidopa. And it helps to replace that dopamine as it crosses the blood-brain barrier, and then it helps to break down the levodopa before it reaches the brain. And I'm not going to ask you on the test how, in every step does this work. I just want you to know this is a first-line drug treatment for the patient with Parkinson's disease. Most likely that's what you'll see first every time. The thing about these drugs, as the disease is progressing, the effectiveness could wear off. So it may be good for a few years. It lessens their symptoms. They're able to continue doing their activities of daily living. But as time goes on, we may need to add another drug in, or we may need to try a different drug altogether. It's really patient specific depending on how they're presenting. There are other drugs, MAOB inhibitors. I would not ask about these drugs in tacapone or tolcapone on the drug. I just really want you to know Sinemet as a first-line drug. But do be aware that there are other drugs out there and that these can promote dopamine. Other agents we might give you are anticholinergics that decrease activity of acetylcholine. So this would be a drug like benztropine, or Cogentin's the other name. This is a very common drug as well. They block acetylcholine in the central nervous system and the peripheral nervous system. You also might see the patient prescribed antihistamines like Benadryl. This has been shown to actually treat the tremors and the stiffness. It also blocks acetylcholine. And they have even tried the antiviral amantadine. Really, again, I want you to know about Sinemet. I definitely want you to know what benztropine is, which is the anticholinergic, and that you might see Benadryl as well. So anytime we're giving a patient drugs that deal with the central nervous system, we want to use one drug and the lowest amount possible. But it's all patient specific. So we'll start at a low dose and see if it helps to relieve the symptoms. The dosage may have to be adjusted or increased. As time goes on, we may have to do a combination therapy and add in another drug. But it's patient specific, and we want to do the lowest amount of drug possible because they have a lot of impacts on the central nervous system. You do need to know that excessive dopaminergic drugs can lead to something called paradoxic intoxication. And this means it would actually aggravate the symptoms versus lessening the symptoms. So if a patient was doing well and then they started to have a really substantial aggravation, this would need to be reported immediately to the physician because this is a concern with the medications. Now, again, because we know this is a disease that's progressing and it's chronic, we know that the patient could ultimately have hypomobility. You should be aware that there's a drug called apomorphine or apokine, and that this is a drug that they give for hypomobility to try and help the patient not lose as much of their independence, if you will. What you do need to know about this drug is that you need to take it with an antiemetic because it has a side effect of nausea. And the drug Zofran, or ondansetron is the other name, is contraindicated with this. The reason I'm telling you that is Zofran is usually the first line antiemetic in any hospital. So this is a case where if they're taking this apokine, they would not be taking Zofran with it. That would be contraindicated because Zofran leads to a risk of hypotension and loss of consciousness with this. So make sure you're aware of that contraindication of Zofran with the apomorphine. Now, there are some surgical therapies out there for patients as they progress with the disease, and the goal of any surgical intervention is to relieve the symptoms. These are used in patients who usually are unresponsive to drug therapy, or as time progresses, they've developed these severe motor complications and they need something other than medications. So one of the interventions you might see is called ablation. Now, this is something that's been used for many, many years. And ablation is where they go in, you may have heard of cardiac ablation, where they go in and actually try to destroy an area of tissue in hopes that it'll stop the damage that's taking place there, or the interruption of conduction in the heart. So they have used that procedure for Parkinson's, but more recently it has been replaced by a procedure that inserts a device for deep brain stimulation. And deep brain stimulation is actually placing an electrode in the brain and then placing it to a generator or connecting it to a generator in the chest. And they hope that by delivering certain currents to the targeted area, it may lessen the symptoms for the patient. So here's an image of a deep brain stimulator. Do keep in mind that any of these procedures do hold quite an infection risk because you're going into the actual brain. You might liken the deep brain stimulator to something like a TENS unit, if any of you have used those for low back pain. It's a similar thing with electrical currents. Now, there are a lot of studies and research being done which involves stem cells. It is a bit controversial because it takes fetal neural tissue and it is very experimental. So you might hear some of that about stem cell research going on to try and find a cure for Parkinson's disease. Nutritional therapy is really important. Again, we know that malnutrition can be an issue because of the difficulty with chewing and swallowing. We know that constipation can be an issue due to lack of mobility. And we need, appropriate diet for these patients. We need fiber, roughage, and they need foods that can be easily swallowed. That's very important so that they don't have a risk of aspiration. We need to cut foods in small pieces, and it's better to eat small, frequent meals throughout the day than one large meal because that can be very trying and challenging for the patient. Something to keep in mind, if a patient is taking levodopa on its own, it can be impaired by protein and vitamin B6 ingestion. So that would be a dietary caution with levodopa. So back to our patient, what are some other emotional issues that he might have? What are some treatment options that we can give him? Well, we're not surprised that anxiety and depression are really a big concern for these patients because of the outlook for the disease. So we definitely want to make sure those diseases are being treated appropriately. We want the patient to know that there are many good drugs out there to help with the symptoms. And we also want the patient to know there's a lot of research going on in hopes of finding a cure. As far as monitoring our patient safety is everything. Again, aspiration risk, fall risk, those are key points with the Parkinson's patient. Now, as we do our nursing assessment, we certainly want to know about any neuro health history the patient might have. Did they ever have any traumatic injury to the brain? Have they ever had any cerebrovascular disorders or a stroke? Have they ever been exposed to toxins? Have they ever had encephalitis, which is the acute infection of the brain tissue? Now, these things could possibly play into manifestations that the patient is showing. We also want to know a lot about medications because we know that there is a drug-induced Parkinson's. And this would be your psychiatric medications like tranquilizers, methyldopa, amphetamines. Because they're impacting the central nervous system, they can ultimately have adverse effects. Respirine, by the way, is no longer on the market. I didn't get that crossed off, so that should not be in there anymore. So as we assess, we're again looking at fatigue because we know that that's related to sustained muscle contraction, excessive salivation because that's a huge concern for swallowing and aspiration risk, and the dysphagia related to that. Weight loss because of difficulty eating, constipation due to lack of mobility, and even some incontinence can be experienced by the Parkinson's patient. As they progress and have more trouble with their mobility, they could definitely, again, are a huge fall risk. They're going to lose dexterity. They're going to have trouble sleeping and ultimately have depression, anxiety, mood swings. So all of this has to be treated for our Parkinson's patient. Things that we can observe is that mask-like face and infrequent blinking. Now, we again naturally blink and we don't think about it. We're protecting our eyes, but that could be a concern for the patient. Parkinson's patients also have an increased incidence of seborrhea, which is this itchy, scaly skin, and a lot of dandruff. And they think that's related to oils in the skin and production, and something they could be experiencing. Also, a great deal of ankle edema, which certainly could come from being immobile and sitting in the dependent position a lot. and postural hypotension when they're changing patients. So you're seeing this as a huge fall risk as well. Again, we're looking for those classic symptoms. So if we're seeing that tremor at rest, that pill rolling movement, they're uncoordinated and they're starting to be forgetful, those are all part of the package that give us the clue this is what's going on with our patient. Other things we might see is that inability to initiate fluid movement, that cogwheel rigid motion, the contractures and the posture changing, and they're starting to shuffle across the room when walking instead of lifting feet. All of that is the classic signs of Parkinson's. So we need to talk about our nursing diagnosis. Well, we've got definitely impaired physical mobility because we're slowing down the initiation of movements. Imbalanced nutrition, which is very concerning because of the problems with eating and swallowing, and we know that the body needs proper nutrition to remain healthy. Impaired communication because of muscles in the mouth. All of these are key, very important, but if we had to pick a priority, of course, that would be impaired swallowing because of the aspiration risk. And then we'd probably go to impaired physical mobility and the falls risk. All of these are important. All of these are key. But when you're seeing different diagnoses, you need to learn how to prioritize what you're going to do to intervene for your patient. Our goal, as always, is to lessen the symptoms, keep our patients independent, living on their own, doing their own ADLs. We don't want them to lose neurofunction, and we want them to have a good psychosocial well-being. So we want to be helping them if they're struggling with the anxiety and depression. Independence is very important for the patient. They need to have that ability to take care of themselves as long as possible. But again, it is a chronic degenerative disorder. This is not a disorder, though, that has acute exacerbations. So you might think of something like multiple sclerosis, where a patient could have an exacerbation, all of a sudden one day they have really extreme flare-ups. Parkinson's is not like that. It's chronic and it just continues to progress and debilitate. So our goals always are about teaching independence, keeping themselves healthy with proper diet and movement as they can, and avoiding any complications such as aspiration, falls, contractures. We want to keep them independent. That's our goal. We definitely want to make sure they do exercise to remain strong, and speaking and swallowing are important. So this is where you would get a speech therapist on board. This is their area of expertise, and they can work with the patient to help them be safe when they're speaking and swallowing. And of course, we want them not to have problems with mobility. So some big things we need to encourage is how to get up, how to move. They may have to initiate their movements in some other way, like standing up and rocking back and forth a little bit until they can get their motion going, because it's not fluid. It's not as easy for them as it is for us. There are some other things they can do, like imagining a line on the floor and stepping over that line. Whatever works for them to help them maintain that independence. Other things we can do is having blocks that go under the back legs of the chairs just to give it a little bit of gravity to help them move. A key thing is removing rugs. Throw rugs are just a real problem for elderly people in general, but definitely people with mobility issues. Excess furniture in the way is a problem. Let's make sure they know to have simple clothing. They don't need buttons and hooks. Let's have Velcro or maybe an easy zipper. Elevated toilet seats to help them not have that increased fall risk. And ottomans to elevate legs to help with that dependent edema. This is all important for the overall care of our patient. We want to help them make these lifestyle adjustments. We want to get them a support system, definitely, put them in touch with that, and also keep the caregivers in mind. They may need to have some special training and some respite care because they're taking on an increased burden as they're caring for the family member. So what are some changes they could make to the home and some teaching for the wife? Well, definitely knowledge is power. So they need to know about the disease and how it's going to progress. We need to be honest and keep it simple. Definitely we could make sure they have hand bars in the house, elevated toilet seat, get rid of those throw rugs, all those things that can keep the patient more safe in their own environment. So the wife tells you she thinks he has dementia. Um, what modifications in teaching would you do to help your patient to understand things? Well, maybe they're not fully understanding it. So, what about giving them written resources or printed resources that they can take home and they can have as a reference? So, put them in touch again with a support group where they can get different resources and also meet with people that are experiencing the same thing. What are our outcomes that we want for this patient? Well, we want them ultimately to be safe and independent as possible. So this means good diet, good physical exercise, assistive devices as needed, the things that will keep them healthy and independent for the longest amount of time. We want them, and this always cracks me up, experience safe passage of fluids and solids from mouth to stomach. We don't want them to aspirate. We want to keep them safe. We want them to be able to talk and communicate as independently as possible. Okay. Several years later, you see this patient at the outpatient clinic with a cough and fever. It is obvious that Parkinson's has advanced. During your assessment, what would you expect to find for this patient? So you're looking over the different things, and you should select D because drooling, stoop posture, tremors, and a propulsive gait are all things that we could see with our Parkinson's patient. An appropriate nursing diagnosis for our patient at this stage of advanced Parkinson's would be which? So read your different options there and always keep in mind patient safety. So risk for aspiration related to impaired swallowing would be the most important one out of these choices. And that about wraps up Parkinson's disease. If you have any questions, please email them to me or ask them in our virtual session, and I will get the back pain lecture out next. Thank you.